Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our sessions in which we review together one of the latest guidelines. As you can see, we are going to review today one of 2025 Irish guidelines, the IVF and ICSI. And this guideline is very important for your exam. And of course, because it's a new one, it's not really new, but this is like an update for the guidelines. So let's see what they are talking about. So this is the original one, as you can see here, and this is our summary. The original guideline, as you can see, is very organized. Start with the recommendation, and then they are going to talk about each and every recommendation and why they reached this recommendation, of course. So I like to start with the definitions. The definitions are very important for you if this is your first time to read about IVF or ICSI. So this could be very important for you. But I'm going to use our summary. Okay, so pardon me, I'm going to close this and continue with our file. So first of all, I should know what is IVF, what is ICSI, and what is the difference between them. Of course, ICSI is more specific than IVF, and we are going usually to use ICSI for severe male factors because I'm going to choose the best sperm for fertilization, and I'm going to do the fertilization myself. This is why it's called intracytoplasmic insemination. Yes. So this is the difference between IVF and ICSI mainly. And the next best most important point is when to offer IVF and when to offer ICSI. But let's start with who should be offered the ART or the artificial insemination or the artificial reproduction. Okay, those who are having problem with their fertility and those who are having female or male factor and they tried something before, like they tried treatments before and it didn't work, or they are having severe female factor or severe male factor, are going to be offered ART. And take care, please, that according to the Irish guideline, it's not a must to offer those who are having unexplained infertility IVF or ICSI. Okay, this is like a huge difference between the Irish guideline and the NICE guideline. In those who are having unexplained infertility, I'm going to offer them IUI. Okay, but in the NICE guideline, we usually offer them IVF. Unexplained infertility, of course, is couples who were trying to get conceiving for like 2 years, and there is no obvious reasons for this subfertility. Okay, another exam question which is very important. Who should be referred to a urologist? This is a very important exam question for you. You are going to have a scenario, and one of the options is refer to a urologist. You shall consider the referral to a urologist when the male factor, okay, is azoospermia, severe oligospermia, with or without urological symptoms, and there is a treatable or a modifiable factor contributing to infertility. Take care, please, because the many options in the scenario would be valid, by the way, because usually the scenario is very simple with no details about the male factor. Only they are going to mention that this male is having azoospermia or oligospermia, and what would be the next option, or what would be the next step. Usually the next step after having the first semen sample is to repeat the semen sample. And this repetition should be within, after 3 months, okay? And for severe factor or azoospermia, it should be as soon as possible to confirm the diagnosis, okay? So take care, please, of the options. And those for consideration, it's not like a routine. Number 2, women should be having a test for ovarian reserve in the form of AMH or antrical follicle account to predict the ovarian response. This is before undergoing IVF or ICSI. Another very important thing is make sure that the endometrial thickness is less than 5 millimeters prior to starting stimulation, which means that I'm going to rule out pregnancy. So I'm just trying to highlight the most important points for you so that you can make your mind about the best next step. Okay, and because this exam is all about choosing the best next step or the appropriate management. So take care of those 2 points. The clinical indication of the IVF, which is by far the most important ever in recalls, it's going to be offered as the first line for those who are having complete tubal infertility. Exam question, definitely. The first line for couples with unexplained infertility, but the woman is over 38 years. Remember when I told you that IUI should be offered for those with unexplained infertility? Yes, this is the exception, and this is why this could be exam question. Again, you can consider the IVF in mild tubal or partial tubal infertility. By the way, take care because this is a consideration, not a first line. And I don't think they are going to bring this in the exam because this needs counseling. Endometriosis with infertility. Again, mild endometriosis is one of the indications for IUI, not IVF. And this is why I'm telling you, this is not exam question. If they told you mild endometriosis, this is IUI. Following previous unsuccessful treatment, whether it was ovarian induction or IUI, yes, this is an indication for IVF. And of course, they should be counseled about whether we are going for IVF only or we are going to do ICSI in addition. Okay. So the indication for ICSI, again, very important exam question. We are going to consider this for male factor infertility, for failed fertilization or suboptimal fertilization in a previous IVF cycle. Let me make it more clear for you. Let's suppose that you had an IVF cycle, but the quality of the embryos were poor. Or after fertilization, the baby couldn't be divided appropriately. Okay, so they are going to tell you that she had poor fertilization or poor embryos in the previous IVF. This is an indication for ICSI. Why? Because I'm going to choose the best oocyte and the best sperm, and I'm going to do the fertilization myself. Again, ICSI is the fertilization technique of choice for SODS oocyte. Typical exam question. No doubt, because this is like an obvious indication, and those obvious indications could be exam question, definitely. ICSI is the fertilization technique of choice for the PGT, okay? So whether you are going to use the PGT-M or PGT-SR, ICSI is better than the IVF. What is PGT? PGT is pre-implantation genetic screening. The types are like PGT for abnormal chromosomal number or abnormalities in the chromosome. This would be PGT-A. If it's done for monogenic disease or like monogenic problem in one of the parents, we are going to call it PGT-M. If it's done because of a structural rearrangement or misarrangement, like a problem regarding translocation, inversion, deletion, and so on, we are going to call it as PGT-S or SR. Okay? Okay. So as you can see here, they are recommending the ICSI for the subtypes M and SR, but when you are doing it for like most of the cases, abnormalities in the chromosome or the chromosomal abnormalities or aneuploidies, okay, to be very specific, IVF is feasible. But when we are doing something very specific, like trying to get an embryo without a specific gene dysfunction or mutation, this could be ICSI, right? ICSI is better. So take care in the exam if they mention PGTM or the SR, as I told you, the structural, like inversion, deletion, and so on. ICSI is better. How this could appear in the exam? They are going to give you a scenario of one of the parents are having microdeletion. For example, the male is having microdeletion, and this is why he is subfertile. Okay, so what type of innovations he should use? The IUI or ICSI or IVF? Of course, ICSI. Okay, the next thing that they have talked about in this guideline, the steps, of course, of the IVF or ICSI cycle, they are the same. The only difference in the last step before implantation, am I going to leave the ovum and sperm work together and the sperm fertilize the ovum without my introduction, or I'm going to do it myself, and this is ICSI. So I'm not really in that they are going to ask you about the steps, but they can ask you about the response. When are you going to call the cycle low ovarian response or high ovarian response? And why we are caring about this? Because if the patient is having high ovarian response, which means that you have found more than 18 follicles, most of them are equal 11 millimeter or more, okay, on the day of trigger, plus or minus, you have collected up to 18 oocytes. That means that this patient is at high risk for OHSS. I'm going to bear this in mind because if I had this cycle cancelled or for whatever reason, this cycle has failed, and I'm going for another cycle, I'm going to bear this in mind. I'm going to choose a specific medications for induction and for stimulation, and I'm going to choose a specific protocol for this woman. This is why this is a very important exam question, also for MRCOG, of course. I just want you to remember what is low ovarian response mean and what is high ovarian response mean, and which one of those is going to put the patient at risk for ovarian hyperstimulation syndrome. Of course, the high ovarian response. Okay, so what stimulation protocol should be used? According to what? According to the ovarian response. So those women who are predicted to have high ovarian response, I should use the GnRH antagonist protocol. And this is what I was talking to you about. This is the exam question. While those with low ovarian response, the first line choice for them is GnRH agonist protocol. Okay, so this is why I'm telling you it's important. Simply, they are going to ask you about this. There are so many details in the steps of IVF and ICSI, and I don't think they are at the level of part 2 MRCPI, okay? However, you should know the basics. Like, for example, we can sometimes use estrogen and progesterone in the middle of the cycle. Sometimes not. It's still debatable. It's case to case. However, we have some basics, or let's say evidence-based medicine around some points in the cycles in general. So most of the guidelines do not recommend pre-treatment with COC if you are going to use fresh embryos. This is important, guys, because I need you to bear this in mind. Why? Because some centers and you may be working in those centers or you have heard about it, that they use the COC as a part of their protocol, okay, to control the induction, okay, or for controlling the endometrial thickness and whatsoever. So I'm telling you, this is like agreed in most of guidelines that pre-treatment with COCs is not recommended if you are going to transfer fresh embryos. About using sewed embryos, this is still debatable, okay? So I'm just trying here to establish the most important points. I'm not going into details, okay? So how we should monitor the IVF? We are going to do it, of course, by TVS. We are going to monitor two things, the ovarian response and the endometrial thickness. Okay, exam question is, what is the endometrial thickness of choice ideally to be before embryo transfer? More than 7 millimeters. More than 7 millimeters. And to exclude pregnancy at the very beginning, I should have endometrial thickness less than 5 millimeters. The triggering, how would you do the triggering? We have many medication for triggering, but if you are going to do fresh embryo transfer, HCG triggering is acceptable, either alone or combined with GnRH. When should we do the triggering? When the follicles reach 16 to 22 millimeters in size. Timing. This could be like 36 to 38 hours prior to collection. So when you see the follicles have reached 16 to 22 millimeters, you are going to give the HCG, or you are going to add the GnRH, okay? Or you could do both of them, okay? And then you can have the egg collection after 36 hours. Again, in antagonist cycles, where there is a high risk of OHSS, and you have given the GnRH agonist, okay, you are going to do a freeze all to reduce the risk of OHSS. This means that you are going to take all the oocytes, freeze it, and you are not going to continue with this cycle. Because if you continue, the risk of OHSS is going to be very high. Luteal support, very common recall. How we do the luteal support? By progesterone, yes, definitely. The most acceptable medication for luteal support is the progesterone. And we are going to give the progesterone support initiated after the retrieval, of course, which is like 3 days post oocyte retrieval. Okay, what about embryo cryopreservation and frozen embryo transfer cycles? You told us before about the most important points of fresh embryos. Again, for the frozen embryos, the endometrial thickness is more than 7 millimeters. Okay, those patients who are having already frozen embryos, they are going to have the protocol for endometrial preparation case to case. So they are not going to ask you about this. Okay, not for part 2 exam. How we can reduce the risk of IVF treatment, this could be exam question. Like, for example, giving capergoline. Giving capergoline for 7 days can be prescribed for women with high risk OHSS. Antagonist protocol, VTE prophylaxis, antibiotics in some cases to reduce the risk of infection in some patients. I want to go down. Yes. Okay. And this is one of the most important exam questions also. The risk factors for OHSS, the signs and symptoms, and how would you manage the OHSS? This is a GTG, so you have to go through it. And we have a recent talk article also, which contains very nice table. You can go through them. So again, while management of OHSS didn't appear so much in previous years, but it can appear now because it appeared before, like the first time management for OHSS, what could it be? It's according to the severity, of course, whether it is mild, moderate, or severe. So let's bear this in our minds, okay? I don't want to talk too much about OHSS here. This is a whole guideline. When should the IVF cycle be cancelled? When the stimulation response is less than expected. When you are having high risk of OHSS, as I told you before. If, of course, medical or social issues arise. And they do not recommend the transfer of more than 2 embryos under any circumstances. This is also important for your exam. They may ask you a question like the patient is asking you to transfer 3 embryos, 4 embryos. You would say what? You would say yes, or you would accept or refuse, or what? You would tell her politely that it is not recommended to transfer more than 2 embryos. Okay? Because double embryo transfer is only considered in selected cases, but the usual practice is to transfer only 1 embryo. Okay, especially if we are having more than 1 good quality embryo. We are going to transfer only 1, we can freeze the other one. We have so many options, but this is like a legal question more than a medical question. And of course, when you are transferring double embryos, couples should be provided with clear information about the risk, because she could be having twins. Okay, it's not like the higher the embryos are going to be transferred, the higher her chances to get pregnant. It's not working like this. Okay, I guess that's all for today. So I need you guys to go through the question that is going to be shared to the Telegram group. I'm going to show you right now. This is our Telegram group where I'm going to share the questions. I'm going to review your answers and spot any incorrect answer, and I'm going to ask you why you choose this answer. Okay, so it's going to be like a very nice technique for examining you. So please, if you are not in this group, try to join. Okay, because right now I'm going to put the questions and I'm going to wait for your answers. Thank you so much, guys, for following, and thank you so much for being so much hard workers. Keep up the good work and all the best for your exam.